Good afternoon and welcome back to ANAwareness Week 2022. Our diamond sponsor, The Ohio State University Wexner Medical Center, has put together an incredible series of presentations for the week. So far, we've discussed multidisciplinary care for AN patients, hearing rehabilitation, and facial nerve reanimation. Today, Dr. Adunka and Dr. Wren are once again their expertise, along with AN patient Borah Dawson, about AN surgery and the patient and provider experience. Bora will share her story and we'll mix that in with lots of Q&A. So please feel free to submit your questions and we'll get to as many as we can. Doctors, I'd like to thank your whole team for the time and effort that you put into these webinars and for your thorough answers to all of our questions. And I want to let patients know we have many resources available on our website. These are relevant to those who are recently diagnosed, as well as those who continue to deal with issues because of their acoustic neuroma. So take a look around at anausa.org. And if you need any help at all, please feel free to contact us directly through email or by calling our office. So now, before we get started, I want to quickly go over how the presentation will work today. All of the attendees are muted, so you're only able to listen. If you have questions during the presentation, there's a Q&A button in your toolbar. You can type your questions there if you're on the webinar, or if you're watching on Facebook, just put them in the comment section. There should also be captions at the bottom of your screen. If you don't see them, you can click the captions button in your toolbar to activate them. If you're watching on Facebook, they should already be there. You may have to go to your settings if you don't see them. We're recording this presentation and it will be housed in the presentation section on the ANAwareness Week page. All of the webinars we've done so far this week are there and ready to view. We'll also keep it on our Facebook page and add it to the video library on our website. There's lots of ways to get involved in Awareness Week this week. You can visit our website and click the slider on the home page to find everything you need to know. I'd like to introduce our doctors. If you've attended this week's webinars, you've probably seen them, but we're really glad to have them back again today. Dr. Adunka is the director of the Division of Otology, Neurotology, and Cranial-Based Surgery at the Ohio State University Wexner Medical Center. And Dr. Wren is an otolaryngologist specializing in otology, neurotology, and skull-based surgery. So now I will stop sharing my screen and we will introduce Bora and let you go ahead and introduce yourself.
Hi, thank you guys so much for having me on today. My name is Bora. I'm 34 years old. I am 1.5 years post-op from my acoustic neuroma surgery, and I have a wife and I have 4 boys and a business owner.
Great. Okay. So tell us a little bit about your life before your diagnosis. What was kind of going on? What were you, what was your day-to-day like?
It was pretty normal. I am more of a rare scenario, I would say. Dr. Adunka, if you would agree, I found my tumor while I was really small and pretty much asymptomatic. I had some minor hearing loss when I was 28 years old after a concert, and after several months of not figuring out what was going on, I had an ENT run an MRI and found that I had this, at the time, I think it was 5 millimeters growth. And it was the first time I'd ever heard of an acoustic neuroma. Mm-hmm. So life was pretty difficult before that.
Okay, that's pretty common. And so just the hearing loss was is that what sort of made you go to the doctor?
Yeah, it was. So I was noticing that I could hear people just fine, but it sounded like they were mumbling, or I was watching TV with closed captioning on at 28. I'm like, this isn't normal. Mm-hmm. And I had some ringing in my ear. And so it was bothersome. And so that's what kind of pushed me to really figure it out. But for the most part, if I wouldn't have had that, I would have known anything was going on.
Okay. And did you go directly to Dr. Adunka in Ohio State, or were you diagnosed like by your ENT, or how did that work?
Yeah, so I was diagnosed by a local to Columbus ENT, and when they told me what it was, they referred me out. And so I think with anybody who finds out you have any type of tumor, you just try to research and find out as much as you can about it. And I saw a few different specialists around the state, around Ohio. And so I got a couple of different opinions, and then I was referred by someone who lives in my town with a different type of brain tumor about the team at Ohio State. And as soon as I met them, I knew regardless of what my treatment plan looked like, that was the team that I felt most comfortable with and that I trusted. So I did see a few and then wound up staying with Ohio State.
Okay. And Dr. Adunka, Bora said that you and Dr. Providello did her surgery. What about her case, made you kind of proceed in the way that you did?
Yeah. So looking back and looking back at Bora's case, it was a small acoustic tumor, right? It was an intracanalicular tumor.
Mm-hmm.
She had normal hearing, at least according to the hearing test, right? I know she had some concerns about her hearing, but we couldn't. It was below the threshold of what the test would pick up, and yeah. So active young mom, really, with a small acoustic tumor, with normal hearing. So really the options were really to watch and wait, right? And to continue to observe this, get another MRI in 6 months, watch the growth pattern, see what we're getting. But dad's, in someone who's that young, obviously carries the risk of just losing hearing from just observation, right? Mm-hmm. And while that certainly was an option, taking it out was definitely, we felt that if we can take it out and front load her risk to the day of surgery in terms of the hearing loss, then we could have a more stable, permanent preservation of her hearing on that side. Mm-hmm. And we didn't feel like she was a candidate for stereotactic radiosurgery just because of her age, and we really didn't know about the growth kind of characteristics of the tumor. Plus, we also felt the tumor was really into her, what we call the fundus, right? The lateral part of the internal canal. Mm-hmm. That if radiation would be applied to that area, that she would have a substantial risk of not just only losing hearing, but also have this persistent kind of pesky imbalance. And I know we're going to talk about balance, I believe, tomorrow. Mm-hmm. So, but we really felt like someone who's that active, right? We wanted to give them the best and most permanent chance of just preserving everything, right? Mm-hmm. That being said, I mean, it looked like it was on the MRI, and we looked at that actually the other day again, that it was a superior vestibular nerve tumor, so the two balanced nerves that we all have, and, mm-hmm. and just to remind everyone, the acoustic tumor comes from one of the two balanced nerves, right? And we don't know which one it is sometimes, but in her case, we actually could see that it's from the superior nerve, so we felt that. With that location of the tumor, she had a pretty good chance of preserving hearing, so about 70%. So, we sat down, and I don't remember this particular conversation, but I think your husband came with you, and we just sort of, stuck our heads together and figured this out. And Dr. Providello was part of that as well, of course. And I think that's obviously what you elected to do. And usually, what I like to do, and I don't know how it ended up in your case, Bora, but I think, I typically recommend folks not to make a decision when they're in the office with me, unless you already know what you want to do, or unless it's really a clear-cut case. I'm like, just mull over what we just talked and go home, talk to your family, and then just call me, email me, whatever, and just let me know what you want to do. I think these rash decisions just in the exam room, I typically, try to talk people out of it, right? Some people are like, yeah, I want to do this. I'm like, yeah, I know, but go home, mull it over, and see if that's really what you want to do, right? So, and I don't know, Bora, if that's how you felt about it, or I don't know. I'd love to hear about your perspective.
Yeah, what kind of things were you thinking about, Bora, and what, how did you leave that meeting?
So I did my normal, scan, and it was June 2020. So we're in the middle of COVID. And I actually saw Dr. Providello first. And at this point, since I think I was on the watch and wait for 4 years, and there was no notable growth. So they found it and it didn't grow, it kind of stayed stable. And then in June 2020, it grew, is what Dr. Providello had said. And I think that's when he was like, I would like you to go over to Dr. Adunka's office, and that same day, and talk with him. But the unfortunate part was, because of COVID, I had to FaceTime. So my husband came with me to get these results, and he's on FaceTime, and we both were like hearing for the first time, because the whole time if it's stable, why mess with it, right? Let it, if it doesn't do anything, it's so slow growing. And at that point, when I first found it, we were trying to complete our family, and so it just wasn't the opportune time. Not that it really ever is, but we, like you said, Dr. Adunka, we had already knew that when it was time to treat it, that we would go the surgical route with OSU, that we weren't interested in the radiation. So when Dr. Pavidella said, I think it's time to do this, we didn't have that added pressure of, okay, so how do we move forward? We already knew, and we trusted what the doctors were saying. And so it wasn't something that we were shocked. We were like, okay, so it's growing. And that was a little bit of a shock, but we knew that surgery was the route for us. And so I think that helped to take a little bit of the pressure off of like, okay, so now I know I have to treat it, but what do we decide? We had already come to an agreement as a family, 4 years prior, that we didn't want to go the radiation route.
Okay. So you watched it for 4 years. And how many kids and how old were they when you were diagnosed, and then when you decided that when it was time to have surgery?
Yeah. So we had 3 boys when we found it, and we were actively trying to have our last son. And that was one of our main concerns, because in a typical type of tumor, sometimes hormones can, affect the growth. And that was one of our main concerns. And we were reassured that there wasn't enough evidence that getting pregnant would really do that. And it stayed stable through that. And then when I had my surgery, which was 1.5 years ago, so at that time I would have had a 15, a 9, a 7, and a 3-year-old. So we have our hands full over here.
Yeah. Definitely, it definitely makes you, I won't say that you don't, I mean, as a surgeon, as a physician, right, you look at the person, you don't look at just an MRI scan. I don't know, we talked about this the other day, and it always helps us understand what's going on in a person's life, with asking these questions, and influence our decision making, right? There's no question, right? So, I mean, you have a young mom on the operating table, right? You want to make darn sure you get her back to her family, right? So I think that certainly ups the ante a little bit. But yeah, I forgot. One point I wanted to make is, and it's interesting, is that a lot of these tumors don't grow in a linear fashion, right? I mean, the fact that you were watching this for 4 years and then it started to grow is not uncommon. So it speaks to the fact that I guess I wanted to let Dr. Wren chime in too, but usually if the first 10 years there's no growth, there probably isn't going to be that much growth, but even then there's some tumors that will continue to grow, right? So yeah, Ian, any thoughts? Do you want to?
Yeah, definitely. I think a couple of important lessons take away here. I think in terms of monitoring, I think it's a lifelong monitoring, and studies have shown that once you start watching a tumor, most of the tumors kind of, if they grow, it's within the first 5 years of observation. But there are certainly tumors that will kind of sit there, and something happens to the tumor, then they start growing, and you may not have any new symptoms. You may not have new hearing loss. You may, but sometimes they just grow, and the only way to find out is following up with whoever's monitoring. It could be your local ENT, it could be the neurosurgeon, could be the neurotology, one of us subspecialists. But I think it's important to get annual scans, because we have seen patients where they had a scan 10 years ago, and maybe a couple, and the tumor stopped growing, and they're like, all right, it's fine. And then 5 years later, they have a sudden loss of hearing, or they have balances off, and the tumor has, multiplied. So I think that's lesson number one. And then number two, I think it's a decision that's not made based on one scan. It's not a decision that's made by the doctor. It's a collective decision. It's made by multiple members of the same team. So I think, I think ANA is a wonderful resource. People exchange oh, this is my tumor, what should I do? And I think that information is important, because it gives you different perspectives, and you can always bring that to the physician, be like, hey, what do you think about this? And I think it's always valid to have a discussion. And exactly, even if people who come into the office knowing like they want surgery, we want to make sure that that is the right thing, because everything has its risks and benefits.
Very,
Well, I think it's such a good, you mentioned, Dr. Wren, that, the team and everything, and some of the best advice, one of the best pieces of advice that I've heard is that the patient is also part of that team. And so they can really add, to that and their perspective and their needs and their, it doesn't always work out, but, in a lot of cases where they can, that becomes important. I think that's a really great way to look at it.
Bora, maybe I can ask you a few questions about, because I remember your post that, maybe you can walk, us and the audience really through, your day of surgery. What was it like for you? And more importantly, really, what was it like for you afterwards? Because I remember, you haven't had a small tumor. I remember you were really, really dizzy, right? Yeah.
Before or after?
After.
After, okay.
So can you, just maybe start of the day of surgery and, in ICU. I don't know how much of the ICU remember, but I think it will be helpful for other folks on the call to understand that.
Yeah, so the day of surgery, I think we had like the first surgery that day. And again, it was COVID. And so it was, I have a big support system, and it was a lot of fighting between my mom and my husband of who was my one visitor. And so, that was a whole thing going into it. But, I was really confident, Dr. Adunka. I really trusted you and Dr. Prevedello. So there was this mild, you don't know what the other side looks like, and you hope that nothing goes wrong, and you hope that you get the results that you want. But there was a very real understanding going into, I'm not guaranteed anything, right? And so I felt very comfortable going in, and I do remember bits and pieces from ICU. I remember the first time I opened my eyes, I immediately vomited. It was pretty bad. I think it took both days that I was in there I remember just having like a washcloth over my eyes, because every time I opened them, if I even slightly looked anywhere, I immediately vomited. So that was pretty tough. I guess I didn't realize how unaffected the balance nerve was until I didn't have it anymore. So that was a little rough. There was, lots of poking and prodding, and I was taken very well care of. And my husband was taken very well care of while we were there. And then I think I was there 2 days, and then I spent 1 day in the step down unit, and then I was able to go home. So after brain surgery, 3 days, when I tell people that, they're like, what? That's crazy. You went home after 3 days? And lots of sleeping. I really struggled to get my balance back to walk. And then I had this weird, when I went to the vestibular therapist with Ohio State, they said it was typical, but I had this weird, in my torso, I shook a lot, which I wasn't prepared for. But yeah, it was just, my husband says the first thing I said when I woke up was, do I have my hearing? And he said yes. And I was so thankful, because, and then I was like, okay, what about my face? Is my face fine? And he said, yes, you got everything that you were hoping for, and they got the whole tumor out. So I was really, I remember that in surgery, and there's a picture, and he showed me, he's like, this is when you were asking me, and I just looked a hot mess. I had the head thing on, and I had washcloths over my face, and I had the thing to catch, vomit. It was not some of my finer days, but I am so thankful that I get to sit here and say, I don't have to worry about my tumor anymore. My kids don't have to worry about it. I, play baseball, and I snowboard, and, I run with my kids. And so, without a doubt, I know that surgery was the best option for me in my case. And I'm thankful that I had such a great outcome, despite some of the, post-op stuff. So,
well, yeah, so let's talk some more about the post-op stuff. I think that's just really, if you don't mind sharing some of that. I think, so the balance was certainly what I remember when you came in for your post-op. Going to the clinic, I think your husband and I really had to sort of carry out there, right? I mean, it was, I remember you were really off balance, right? And your compensation, like you said, with your torso, I think you just really tried to compensate with your hips more so than with your ankles and other, so certainly we see these different patterns. But I mean, how was that rehab process for you? maybe you can, I think it would really help the attendees to understand that. You know?
It was really good. I was really thankful for the support I had. So I think within that first week, before I was even 7 days post-op, we had already gotten our appointment and got in with the therapist. And I think that what I didn't realize, and it would be, you know, if you had surgery on your arm or your leg, there is a certain time that your body needs to heal, and it's with anything, right? And so I went to therapy, and I couldn't even like lift myself up onto a walker because I had just had surgery. So I was like weak, and I was still, you know, I was on a lot of medicine. And so I remember her telling me, she was like, I don't think that you're ready for this. And I was devastated. And I'm like, I can't not take care of myself. I can't not walk. And I think there's like this part of it where you're like, I'm superhuman and I just had brain surgery, but I want to be up walking and taking care of my family. And so it was like a very surreal moment when she was like, I think you should wait like 2 or 3 weeks. And I'm like, I'm not waiting 2 or 3 weeks. Like, I'm going to walk. I need to figure this out. And so I think I went once a week, and then twice a week when I was like more stable. And then I think my therapist had said, you know, realistically, you're looking at, I had my surgery the end of August. And she's like, I think that you're looking at December, Christmas time to walk unassisted, like no walker, no cane, like back to normal. And I'm like, that doesn't work for me. So I think I was completely fine by trick or treat. I walked completely normally with my no balance issues. The big thing was once I got my balance, if I would have turned my head, I would like, you know, have like that whooshing feeling. But it was like October and I was totally fine. So it just, you know, giving yourself, I think the healing process, like letting yourself heal for a little while before you jump right into rehab is, I think, the mistake that I made a little bit, because, you know, you just have to, your body needs rest to heal.
Yeah, I think it's a good advice, Bora. And I think, you know, we usually push patients out of bed as soon as possible, right?
Yeah.
But on the other hand, you know, there needs to be a balance, I guess, right?
I think there is a public video of me walking for the first time on TikTok. So if you want to know what that looks like, that first step after brain surgery, it is out there.
I definitely have seen that video and attest to that. That was how you walked, you know. Yeah. So I think, and we have some questions in the chat, and we'll get to all these. It's just one thing about the process of your surgery was, so you woke up with a normal face, but I believe you had some, what we call a reactivation policy, right? So your facial nerve was fine immediately after surgery. And then I don't know what the timeline was exactly, but you had what we call a delayed facial paralysis, right?
Yeah, it was 7 days post-op.
7 days post-op. How did that sort of start?
That day was really weird. I remember waking up that morning and going to brush my teeth, and like the corner of my mouth felt funny. Like I hadn't really lost function, but I felt like it was weak. And then, you know, I had I went through this, I started getting sick, and like I had like that weird jerk. And then all of a sudden, like I just felt like as the day progressed, like I couldn't move that side of my face anymore. And with anything, you know, we called the team and we're like, hey, we have like a sudden onset of something changing. And so, you know, we wound back up at the hospital just to make sure everything was fine. But it was, what is it, like 20% get that after Dr. Adunka? I feel like
you know, delayed is rare, I would say, right? I mean, we hardly, I mean, we don't see it often. I would say it's far less than 20%, you know.
That's one of the questions on Facebook is, if a tumor is in the CPA, in the cerebellum, whatever you guys say it, what percentage of affects the facial nerve in those kinds of surgeries?
Well, I think that the risk to the facial nerve increases with tumor size. You know, for middle fossas, so there was another chat. So Bora had a middle fossa approach.
Yes,
right?
That's what I was tumor.
I think there was one question on that. And you know, for small tumors, we hardly ever have a permanent problem, right? I think if you have a tumor that's 2.5 centimeters or less, it's rare with an experienced team to have a permanent problem with dysfunction of the facial nerve. With larger tumor, that risk certainly increases, right? And what I often tell folks is that when we go with the MRI, you know, usually pull it up on the computer that's in the clinic room, let me talk about some of the specifics. And the size alone is not what determines the risk necessarily, right? The size certainly is part of it, but there's some other factors like cystic components within the tumor and how far the tumor extends anteriorly. Those factors really affect, with bigger tumors, really affect the risk to the facial nerve to surgery. So I don't have a perfect number, right? I just caution about a number because every tumor is so different. The other thing we look at, or we try to look at, I should say, and it's often hard to tell with larger tumors, is that interface between the brainstem and the tumor. And again, with larger tumors, and sometimes we have MRI findings that would suggest quite a favorable one, meaning that the tumor will strip away from the brainstem, and that usually also means, not always, but the tumor also strips away from the facial nerve. So there's some detail, like with everything in life, right? There are a lot of details, and those do matter, right? So it's hard to put one number behind a certain centimeter of tumor, right? So I think for small tumors like Boras, right, where the size really matters some, but for middle fossa tumors, again, those are limited by literally a centimeter, about maybe a centimeter and a half max, right? But really we try to keep it below a centimeter in terms of indicating that approach. We hardly ever see that, right? I mean, but if it's the delayed injury, like 7 days later, we pretty much know it's going to come back perfectly, right? And despite us telling you that, Bora, you're probably still kind of scared, probably. I don't know. I mean, any thoughts about that? I mean, it's kind of scary when your face doesn't move.
Yeah, and it really did move. My eye, nothing. I couldn't blink.
Yeah.
I wore the eye patch and put the stuff in it. And so what they were saying, don't worry, just give it time. I'm like, I can't have half my face not for the rest of my life, but it did. And I would
How long did that take, Bora?
Yeah, how long did that last?
I think 4 total weeks. And then it was really strange because, I had like the complete weakness, and then there would be days where I could feel twitches. Like I could, sometimes where your eye twitches, I could feel it. And then I would wake up the next day and I'd have like a little bit more function. And so like I kind of grew to love these weird facial twitches I would feel, because typically it meant there was going to be more movement the next day. But I think 4 weeks, and the only thing that I really struggle with now is I still don't cry from my right side, which Dr. Adunka said is normal, but it keeps itself moisturized on its own. It blinks, it responds. It's relatively the same size, but I still don't cry from that side.
Mm-hmm.
Yeah, there's a little nerve that runs on the floor of the middle fossa. We call the GSPN, that provides fibers, nerve fibers that supply the tear gland. So that's common.
Did you get steroids when your face was out, in that 4-week time period?
Did I take steroids?
Mm-hmm.
I don't remember. I was on a lot of different medicines, and my husband kind of took that over to make sure I got the right ones at the right time, at the right frequency. So there very well could have been steroids. The only thing I think I remember was I was on an antiviral, and I think Dr. Adunka, your team switched it to a different one. And then that's the only thing I remember as far as medications go on that side of it.
Yeah, just a few words. I think you were on a steroid. I would have to verify that, but that's what we would usually do.
Mm-hmm.
And the antiviral is really interesting because Bell's palsy, when you usually have a facial weakness without any kind of tumor there or anything like that, we do think that's due to a virus that sleeps in a nerve ending reactivating. So in delayed paralysis, we feel like that we believe that the stress of surgery will reactivate a virus that ultimately, causes swelling of the facial nerve. So does the antiviral. There is some data on it. It's not the most solid data set that we base this on, but the risk and benefit of taking the antiviral is really really not a big risk to that drug, right?
Yeah.
And, I think there was one question in the chat about how long it would take the facial nerve to come back.
Mm-hmm.
So I think for these delayed paralyses, so 4 weeks, what you said would sort of be a pretty common scenario, right? Wouldn't you say, Ian?
Yeah, I would agree. I think, definitely within a couple of months. I think the delayed ones, they almost always come back. It's it's hard, I think, as the patient to hear that and be like, oh, the doctor says it's okay, but the face is still out, and every day you look at it, nothing changed, but it will come back. And this relates to something Dr. Kim and I were talking about yesterday. There's not a whole lot that the patient can do to speed that recovery up. It's not like, oh, let me just take a medicine that will help speed up the recovery. The facial nerve will recover, but it does so at its own pace. Sometimes people ask, should I get massage? Should I get acupuncture and things like that to help stimulate the muscle or help recover? And Dr. Kim made a good point. She said, they're not going to hurt. If that makes you feel good, it's okay to do them. The only thing we caution was don't have them put electricity through those needles, because we want the face to regenerate the facial nerve to kind of make the connections. If you send electricity, that actually can interfere with the body's own recovery. But delayed ones, they almost always do recover.
So that's important for us, the delayed versus the immediate, right? So if you have if your face is weak right after surgery, right, that may take longer, right? Take up to 6 to 9 months. So if you wake up with facial paralysis and your surgeon guarantees you that the nerve was, what we call the cable was still intact and was still connected, then that would probably take 6 to 9 months. So it can be very, very, very frustrating. And that's why we're so careful about facial function. So it's absolutely.
Dr. Adunka, how often do you recommend that patients do follow-up scans? We have a question in the chat about that, but then also on Facebook, since Bora had a complete resection, how often does she have to go back and check and see?
Well, I'll give you my kind of version, and then maybe Dr. Ren, because there are a bunch of versions out there of what people do after surgery. And so I think it depends a little bit on the initial tumor size, right? With a small tumor, we would usually confirm the gross total resection with a scan, somewhere a few months after surgery, and then probably get a scan 5 years later. That's what I do. Dr. Prevedella, right, the neurosurgeon I usually work with, get scans all the time. So Bora, you probably had some more scans, and it's just the threshold for neurosurgeons to order an MRI is very low, right? And but if there's a gross total resection, meaning that we've taken all of the tumor out, at least all of what we can see, that I would get I would confirm that and then get a scan 5 years later. I don't know, Yin, any thoughts on your?
Yeah, so I think it highly depends on how much tumor was left. If we took the whole tumor out, we would call it gross total, meaning under the microscope in the operating room, we believe we got all the tumors out. Now, that doesn't mean every single tumor cell is out, but everything we could see is removed. I usually do a scan at 1 year, and then 5 years and 10 years. And if they're clear at 10, they're done. But if there's a little bit of tumor remaining, now that little bit, depends on how much. If it's a near total resection, meaning we just left a tiny sliver, usually on the facial nerve to protect it, I usually get a scan a little sooner. And sometimes it's coordinated with neurosurgery. So some could be a few months or 6 months after surgery. If there's more tumor left, we probably would get scans a little more frequently within the first couple of years after surgery at a more regular interval, just to monitor that remnant. So I think it depends on the extent of the surgery for removal of tumor.
Maybe to chime in here too, and I would agree. Sometimes, if a remnant is left, meaning a subtotal resection was performed, right, this remnant is usually a veil. So what happens is you leave a veil of tumor over the facial nerve. And if you follow that remnant with MRIs, you see that the veil usually will ball up into another ball, essentially, and that usually takes about 3 months, right? So the first 3 months, and then you would have that baseline to basically follow the girth of the diameter of the tumor, right? So that was that. I think one question I saw here in the chat, Melissa, if you'd allow me to.
Absolutely.
Because I wanted to Dr. Ren's kind of opinion about that. I think one person asked about aspirin and
Yeah.
following the tumor, right? So do you have any thoughts?
Yeah, I think, there have been several studies. I think the first one came out of the Mass Pioneer. They were looked at kind of retrospectively. So meaning, it's not like let's treat half the patients come through the door with aspirin, the other half without, and see if the tumors kind of grow differently. So this was looking back at the past, I don't know the exact timeline, number of years, looking at a group of patients and separated them based on those who took aspirin and those who didn't. And they found that those who took aspirin, their tumors were growing less than the tumors that did not get an aspirin. So this was followed up by several other studies at different centers. One was done through Vanderbilt, a big group, and then the other one at UT Southwestern, another large center. And they did not find such relationship in their series. So aspirin, whether someone's taking aspirin or not, did not impact the growth of the tumor. So I think the jury is still out there. There's certainly the theory behind this is we think, aspirin is an anti-inflammatory, and there's some evidence to show that, there is some pro-inflammation that goes on in the tumor. And so if we sort of give the anti-inflammatory effect, maybe that will help reduce the tumor growth. And, since so many people are on aspirin anyway, and it's a fairly well tolerated, why not try it? But I don't think there's a definitive evidence to show, oh, if I take aspirin, my tumor is not going to grow. In fact, if you don't have any real indications for aspirin, there are side effects, right? You can have bleeding, you can have GI ulcers from all of that. So I don't think it's something that, a patient should just start taking. I think it deserves a conversation with the physician.
Then the next question I have for you, Yin, is one person in the chat asked about hormones.
We have one about that on Facebook as well.
Yeah, so
that's an interesting question. I think for, there are brain tumors like meningiomas, which is a different type of brain tumor that we call it fairly common. It's not common per se, but it's more common than vestibular schwannoma or acoustic pneumomas that can occur in the similar areas. Those are more hormone dependent. I think there's a lot of data on that. For vestibular schwannomas, I'm not sure if there's evidence to show, sex hormones like estrogen or something can impact tumor growth. So I'm not aware of large studies that show that. There are probably smaller series that showed, gender could affect it. But I think if you take, multiple centers, multiple studies over many years, I think that effect kind of goes away.
I'm not aware of something either. I think one question I saw was a good one to shingles related Bellsprout. So the reactivation is actually not the shingles virus. What we think of it is what we call the herpes simplex virus. And it's the same virus that basically causes cold sores, in the summer when you go in the sun and you have, sores in your mouth, right? So that virus would not cover that, right? The syndrome in the ear that's associated with the shingle virus is called Ramsay-Hunt syndrome, right? And that is quite a severe version of Bell's palsy, I would say, with pain and, the people can drop the hearing too with that. So, but yeah, for acoustic tumors, the shingles virus would not aid in that, right? So shingles vaccine, sorry, would not help with that, right?
Bora, was your vestibular nerve cut? Do you know? Was it?
Yeah. So let me answer that.
Yeah.
So acoustic tumors, really, we talked about it during one of the other webinars. Are really balanced nerve tumors, right? They come from either the superior or the inferior division of that balanced nerve. So we're unable to remove acoustic tumors without cutting that nerve, right? Because they become the nerve, right? Or the nerve becomes the tumor, whichever way. So 100% of acoustic tumors, if you remove them, you have to cut the balanced nerve, right? And the fact that Bora is not dizzy anymore, I hope you're not anymore, but I think you're moving just fine now. So it's really because the brain compensates. And what that means is that the other side eventually takes over for that loss of balance function from the same side the tumor is at. So yes, we did cut Bora's balance nerve, and that's again, that's that we couldn't remove the tumor otherwise. Yeah.
And do you have any symptoms that you are still struggling with now, Bora? What do you deal with now?
I mean, I still have like mild hearing loss, and it's like in a situation like this, I'm totally fine. But if there's any type of background noise, it is very hard for me to differentiate some of the words that are spoken. It's kind of like, what did you say? I'm so sorry. Can you repeat that? I still watch TV with closed captioning on. I don't know if it's a habit now or what, but no, not really. And this is so wild too. And I don't know your opinion on this, doctors, but leading up to my surgery, I started having headaches almost every day. I've always been prone to migraines, and I would get them frequent. But probably the last 3 to 6 months, I got headaches almost every day. I was taking, Advil for these headaches. And post-op, I had lots of headaches for different reasons, but I hardly have headaches anymore. I probably had one migraine in the last year and a half, which is, I don't know how related it is, but
Okay, right.
Yeah, it's great to hear, and we're happy to take all the credit for it. No, I'm just kidding. It wouldn't be expected, right? That your headaches would be improved or even go away. But it's interesting that we do see these kind of stories, right? We do see the kind of headache story. We can't perfectly explain it through a mechanism, right? Through a cranial nerve that was affected by it, and now it's not. But I've certainly seen it. That wasn't the intention of your surgery, the primary, but certainly is a wanted side effect. Yes. I don't know, Yin, do you have any?
Maybe related, there was a question in the chat for Bora. How much pain did you have post-operatively, and how long did it take before you felt better?
So pain-wise, if we're talking incision, I had no incisional pain at all, and I'm not sure what causes that. It was more of a fullness, and I had a lot of headaches afterwards, but I had a lot, my jaw was probably, if I were to say the worst thing post-op, like pain-wise, was my jaw was very sore. But I would say week 2 was a turnaround week for me. The first week was very tough, but week 2 was good. And then from there, I saw steady progress, but week 2 was a big week for me with pain. So my incision really didn't hurt. I mean, even getting my staples out with you, Dr. Adunka, I was really nervous it was going to hurt, and it didn't. I don't know why, but every once in a while, when the barometric pressure changes, I'll get like a little sore on this side, but the pain wasn't the issue. It was just like a lot of pressures and headaches. Like I felt like I had a constant headache after surgery, but I really wouldn't say it was painful.
Yeah, it's pretty common, I would say. The pain is really relatively mild. Incisional pain, and then of course headaches for some folks. But it's not extremely painful, either approach really, right? I mean, if it's done right.
Yeah.
We're careful with the retrosigmoid approach, where the linings of the brain and the muscles of the neck can sometimes interfere, right? We're really careful of separating these, right? Because when those muscles get in contact, when there's a gap in the bone, which will grow in eventually, but if that gap in the bone allows the muscle to basically get in touch with the linings of the brain, the dura, that would cause extreme pain, right? So we're very careful about that, right? But I think we had some more. So vestibular nerve, we talked about that. I think that was about steroids, how long the steroids, right? So what we usually do is a steroid, what we call a taper, right? So we do usually 5 days of prednisone. And, across the country, you'll see anywhere from, I think, 2 to 7 days probably of a higher dose, 60 to 80 milligrams. It depends on, the overall kind of, weight of the patient. Obviously, Bora is very, thin, and so 60 is a lot for you, right? So I think we give you 60 and then a taper, right? And has to do with just the physiology of the adrenal glands, so that making sure they continue to produce steroids that the body produces, right? So I think that does the taper, but that's usually what we use. I personally use 5 days and then taper it off. Any thoughts?
Yeah, I do similar, for facial paralysis. So everyone's protocol is a little different. But 5 to 7 days of prednisone, usually at around 60 milligrams with a 4 or 5 day taper. I would just say, the steroid that often people think about is they get this, it's called a Medro dose pack. It's like 5 tabs. You take 2 tabs on one day and then one on each the other day. That dose is pretty low. So I think the dose that we use for facial paralysis is much higher. And for, if you have a sudden hearing loss, the dose you would get, the therapeutic dose would be much higher than the Medro dose pack.
I think if I may jump to a question, Melissa, there's one. A person asked about the relative sensitivity of some of the cranial nerves, right? And this person mentioned trigeminal nerve, facial cochlear nerves, to surgical insult or dysfunction, right? And why are we not routinely monitoring the trigeminal nerve, right? So there's some mouth numbness, I think. So I'd be curious to see what you feel about it, Yin. But so in small tumors, we don't monitor it because the tumor doesn't get anywhere close to it, right? It's really just tumors who touch the facial nerve, and depending on the configuration of the tumor and the size and shape and all that, it usually takes about 3 centimeters of tumor before we actually see that, right? So it really, and that's really why we recommend getting these scans, right? Because the only new if you have an asymmetric hearing loss, and you don't act on that, meaning you don't get a scan, right? 15 years later, after the tumor has grown, it would cause facial numbness because it pushes against the trigeminal nerve, right? And that's really sort of our because there's no new symptom, right? Because you lose hearing, you just blow it off, and we see that constantly, right? So that's really the main reason to get a scan, is because we want to avoid the tumor touching the trigeminal nerve. And obviously those are bigger tumors, right? So for bigger tumors, it's hard to monitor the trigeminal nerve because it's a sensory nerve, right? The facial nerve is a nerve that has a specific function. It moves muscles in the face, and we can put electrodes in those muscles in the face and monitor it, right? With the cochlear nerve, we know it's hearing, right? So we can monitor hearing because of the specific function, and we have a test for it. For the trigeminal nerve, we do really for the sensory function, meaning that, the sensitivity to touch, we really, there's no good monitoring test. And the trigeminal nerve, however, has a motor branch too that moves a jaw, right? And we could monitor that. The reason we don't usually monitor is because the trigeminal nerve is by far the biggest cranial nerve, right? It's a big nerve. Usually the tumors, they're easily dissectable from the trigeminal nerve, right? That being said, I did have a few cases where the tumors that are quite aggressive tumors can really carve out a piece of the trigeminal nerve. We have seen that, and the monitoring would not improve that, right? Because usually the dissection off of it, even in those cases, is relatively easy. But so if I had to order this, the question in terms of order and the relative sensitivity, I would say the cochlear nerve is very sensitive, and the facial nerve, and I'll put the trigeminal nerve last. But it certainly is, it's a big nerve, right? There's a lot of function of it. Anyway, Ian, any thoughts?
Yeah, I mean, I completely agree. I think, we don't monitor it. One is because the tumor usually doesn't affect it, it sits further away. It's still all a very small space, but when we're operating in there, you could clearly see there's a sort of a gap between where the tumor is, even when they're sizable, and where the trigeminal nerve is. And it's the motor part of the nerve, sometimes we do monitor in huge tumors. Sometimes we do different approaches, sometimes more so for meningiomas, other types of skull-based tumors that are sort of arising from an area where the trigeminal nerve kind of traverses, and the nerve either gets pushed towards the middle of the head because the tumor is growing on the outside, or sometimes the nerve gets pushed towards the outside because the nerve is pushing it from the inside. In those cases, certainly people can have trigeminal nerve issues. So numbness on various parts of the face, as the trigeminal nerve supplies the face in kind of 3 zones. I think without details about what type of tumor, what type of surgery, we don't know, what exactly part of the nerve is affected, but in general for, acoustic neuromas, they're usually not kind of reaching that size to affect the trigeminal nerve. But everything else I would agree.
So
Dr. Adunka, go
yeah.
ahead.
no, that's I think I just going through the chat here. So nutritional supplements, I don't think there's any evidence that those would make a difference.
Yeah.
So unfortunately, I wish they would, but there's really no. Maggie here asked a nice question. What I saw, if you have balance issues before surgery, how frequently do they improve post-op? So the easy answer is almost always, but because taking the tumor out removes these aberrant stimuli of the balance nerve towards the brain, right? And the brain likes consistency, like every day is the same. And cutting the nerve is usually better than having a bad nerve. So having no nerve is better than having a bad nerve, right? And so typically speaking, they do improve or even completely disappear. I think it's a little bit age dependent. Someone like Bora, who's young and healthy and very active, it's usually folks can do whatever they need to do. And I hope that's the case, Bora. And some other people who are older, right, we do counsel them much more heavily about some residual dysfunction. That being said, sometimes in older folks who've lost their hearing and have substantial balance issues or would otherwise just watch the tumor, we would actually go ahead and take the tumor out, right? There's some other surgeries or what we call gentamicin injections into the ear that oftentimes can help with that, right? But I would just advise you to consult with your physician and really have a detailed discussion of what the options are, right? I mean, removing it is certainly one of them, but there are some others, right?
Yeah, and I think we will address some of that balance issues both preoperatively and postoperatively with, our physical therapists who does this every day, so they will be able to give some details about, what kind of issues. So I think that would be nice. Yeah.
And I think the other chat question here about the centers of excellence, right? And really the question is the number of surgeries that's been well shown, right? There's a learning curve. Learning curve. The folks in the UK have shown that as well as others. I think the best data, correct me if I'm wrong, Ian, is from the folks at Cambridge, and they've really shown that once a team reaches again, neurosurgery ENT has reached about 100 cases, their results are relatively stable, right? And a lot of results are driven by the biology. So what I mean by that, for a well-oiled machine and a established team that has these 100 cases under their belt, the biology of the tumor, meaning how stuck it is, how big the tumor is, where it's exactly located, if it's cystic or not, how firm it is, those are all factors that would ultimately drive the result, not necessarily the specifics of surgery at that point, because you have that team and they're so consistent, right? But again, it does take 100 cases, right? If you look at the literature on this. And I would say that it would be great to have centers of excellence. Unfortunately, there's no governing body over this, right? And we do see folks who are not well trained to do these cases, right? They're not well trained in counseling you, right? And the surgery is part of where they're not well trained, but it starts with the pre-op visit, really. And so it's just, and I mentioned this, and Dean mentioned this also previously, it's just good to have that team, right? And to have really the center with PT, with, Dr. Kim was here, you want the neurotology, you want all the neurotology expertise, because of balance, hearing, et cetera. You don't want to just have one doctor doing your case, right? And I think ultimately, Bora, I hope that was part of why you felt comfortable with us. But you want this, it takes a village kind of approach.
Yeah, I think it's a rare disease, right? So You know, it's not like, oh, let me just find my neighbor who has hypertension, see what drug he's taking. And the treatments, I think what's really unique is there are multiple treatments that may all be valid options. But I think it's really a patient-centered process, and, you know, use as much resources and time. You know, it's not going to change, you know, life or death in the matter of a day or two. I mean, some tumors are huge, then we need to act on it quickly. But for the most part, you know, I think take the time, and, you know, sometimes if you're, you know, in an area that you know, don't have local, for example, you know, AN patients, you know, reach out through ANA. There's support groups throughout the country. And I think just going to a center where there's multiple specialties, where there's experience is key, because, you know, it's as you know, we've shown before, if someone's been there before, if you've had surgery, you've had radiation, and tumor starts growing again, the treatments are more difficult, more challenging, the morbidities are higher. So it's always good to pick the team that can do this right the first time.
Yeah. Bora, I wanted to ask you if there was anything that you did prior to surgery to kind of prepare. I'm sure the logistics of trying to get ready for surgery were a handful, but I wanted to know physically and mentally, sort of, what did you do to get ready for this? And what would you advise for patients who are getting ready to go through it?
You know, it is a lot, because I have a large family, and we have, you know, little kids and middle kids that are in lots of sports. But I think we decided that we would do surgery in June, and then my surgery wasn't until August. So I really just took the time to spend time with my family, and we just focused on that. And then August 1, I'm like, okay, now we really have to like get this together. So it was, you know, my mom stayed with us for 4 weeks, and friends of mine created a meal train so that my family could just focus on healing. So we had meals delivered, which was amazing. We had more food than we could ever eat. And then it was doing the research and being a part of the ANA, and just reading different blogs and people's experiences that had my approach. And I was really thankful, because I never thought or knew about possible jaw pain afterwards. And so they were like, you know, it might be good to just have like soups and broths and soft stuff, just in case you wake up with a little bit of a sore jaw, and it's better to have it than not have it. And so I was able to stock up on that kind of thing. You know, just really getting involved in the community of the acoustic neuroma patients, and figuring out what worked well and possible side effects or things. I did a lot of research. I did a lot just to cover all my bases. And it really gave me confidence, knowing that my team is a well-established team, and I really trusted them. So there was just sort of this piece of knowing I was going to be taken care of in surgery, and then everything was kind of taken care of by my husband and my mom. So I actually kind of miss it. Everyone taking care of me and catering to me.
Well, with 4 boys, it seems like you're taking care of other people now. So
Exactly. Exactly.
you know,
Dr. Wren, is it common that we have a question on Facebook where I know Bora didn't have a lot of symptoms preoperatively, and her tumor is fairly small. With a small tumor like that, like 4 millimeters, 5 millimeters, we do have patients that have some pretty severe symptoms. Is that?
Yeah, absolutely. I mean, I remember having patients with a small tumor like that lost all their hearing. And I remember other patients with a small tumor and are falling, like they're just having severe vertigo. We still don't, you know, understand everything about it. And, you know, it's not just like the tumor is small and doesn't really push on the nerve, and therefore it doesnent cause symptoms. So yeah, certainly it varies a lot.
I think one question was about the number of cases a year, right? There is no absolute number, I would say. You know, arguably the combination of neurologists and neurosurgeons should probably do about 20 cases a year, right? At a minimum, I would think. But I mean, it depends on how established that team is. What have they done in the past? You know, I would have a hard time putting an exact number to it, but you know, again, keep in mind is that the learning curve is about 100 cases, right? So over the year, so.
Or were there some milestones that you had kind of put out there for yourself, and, you know, based on the research that you had done, and then how did your expectations meet reality as far as meeting those throughout, you know, over the course of a couple weeks to a couple months to a year or so?
Yeah, I don't think I was prepared for the vertigo, or is it considered vertigo if you don't have the nerve on that side? I don't think I was prepared at all for that part of it.
Mhm.
I don't know if I just was naive and I'm like, I'll be fine. Like it, so that was a shocker for me. So going through that part of relearning how to balance myself and then hearing my PT say maybe Christmas, I'm like, I don't think so.
Mhm.
We can't put our lives on hold for 6 months. I'm
Yeah.
healthy, I'm young, I can do this. And so it was kind of like this competition of every time she'd give me a new, okay, well, you're doing better, so maybe Thanksgiving. And then I'd be like, the next time I'm going in, she's going to tell me this. And so it was kind of doing that. But I think the biggest milestone for me was when we realized how much I struggled with my balance. Was she was telling us, you might not be able to snowboard again. And that's something my husband and I really enjoy, and it requires quite a bit of balance. And so that was a huge milestone for me. Don't yell at me, Dr. Adunka, because I think you guys told me to wait more than 6 months, but 6 months after my surgery, so the January of 2021, my husband and I went snowboarding. I wore a helmet and I did the bunny hill, but I did it. So that was huge for me. It was monumental. Like, it was one of those things that I wasn't sure if I was going to be able to do. And I've done it again since. And so I think it was just giving myself, beating like whatever the next milestone was for my physical therapist. I'm like, nope, I'm going to do it before that. And I did. So.
Well, and I would say, I'm glad you can do what you want to do, and I expected that, frankly. But I think motivation goes a long way, right? And we see that with other problems that Dr. Ran and I treat. That if a patient's really motivated and they're really behind the rehab process, it helps a bunch, right? So being just taking that in your own hands in a way, and be motivated and.
Absolutely.
And driving that timeline, right? I think it can be a little too much, right? We're driving it too much may actually cause a setback, but typically it's a good thing.
Yeah, I mean, I prefer to tell patients, oh, slow down a little bit, rather than you gotta start moving. Sometimes patients ask, oh, can I get like a handicapped parking pass because I'm dizzy, I can't walk. I was like, no, this is why you have to walk. But yeah.
We're getting toward the end of our time, but I did want to ask one last question, just Bora, about your kids and how you spoke to them and how you talked to them about what their expectations should be as far as your surgery and your recovery and how long that was all going to take.
So I think it's a little bit different because I have such a wide range of kids. So as a teenager, we were just very honest and open, and he received it pretty well. He's pretty, teenagers are just, I feel like sometimes it goes right over their head. But our youngest had no idea what was going on, but our middle two, we tried to approach it in a way that they wouldn't be sad or afraid, just because after surgery, we didn't know what was going to happen, but we didn't want to blindside them either. So we just told them that they knew I had a brain tumor, and we used to joke because we named it Eugene. So we were like telling them Eugene was going to come out. And so I think that at the time they didn't really understand, but they knew that I was going to go. And I think that when you're going through something, you don't really notice what's happening. And so my first parent-teacher conference, like post-op, where I was like back to normal, the teachers had said, things must be going really well for you. And I'm like, oh, why is that? And they're like, well, Titus came to school and he's just like smiling from ear to ear. So, we really hadn't seen that from him. And you don't realize how much kids worry about you. So even though we did talk to them and, give them an idea of what would happen, they still carry that burden a little bit, but, they love that I don't have to worry about my tumor anymore. Like, our lives are completely different. There's nothing like holding us back or being worried about, or maybe one day I'm going to wake up and mom's face is going to be permanently paralyzed, from here forward, this is my mom and this is what she's going to be. And they're thankful for that. And the very first baseball game that I went to, it was the last one for my son. I really couldn't walk long. It was kind of far away. So my husband had to drive me up, and he was just thankful that I was there. And so I know when I go to his baseball games now and I'm like normal and I can drive myself, which was also a big milestone, driving.
I saw that video.
Yeah, it was, it's that head motion that gets you.
Mhm.
But yeah, so it's great. Everything is good now, and we couldn't be any more thankful to be where we are right now, even given that small time in our lives where it was kind of rough, you know. I would do it 10 times over to be where I am today and not have to worry about it anymore.
Yeah.
Right.
Thank you very much for taking the time to share your story. Dr. Adunka and Dr. Wren, as always, thank you for sharing your expertise and answering all these questions. We were always happy to have you. And thank you to everyone who attended today. We have one last webinar tomorrow. As Dr. Wren mentioned, it's going to be on balance. So we'll have some physical therapists here to talk about that. And hopefully Dr. Adunka and Dr. Wren will be able to join us one more time. That presentation is scheduled for 3 o'clock Eastern, 12 o'clock Pacific. And so we will see you back here then. Bora, thank you so much. That was really helpful.
Thank you, Bora.
Thank you. Thanks for sharing. Yeah.
Yeah, thank you. Have a great night.
Thanks, everyone.